actually as part of the World Antibiotic Awareness Week, which is observed every year from November 18 to 24. So this year we have planned, this is actually one of the several activities in store during this week. It's a webinar series. So we will start with a roadmap to make the Kerala an antibiotic literate state. That is, this is basically a sort of a generic topic about what we should be doing, the One Health importance of One Health engagement, how we should be making the people aware of the importance of antibiotics, how precious antibiotics are to us, etc. From tomorrow onwards, we'll be having specific sessions. That is, tomorrow, Kavita Raja Madam, the head of microbiology from Sritra, will be speaking on how we should be interpreting the cultures, which is actually the diagnostic stewardship is a very, very integral component of antimicrobial stewardship. On day 3, we'll be having this AMS, antimicrobial stewardship in practice in the OPD. On day 4, in practice in the IPD. Day 5 in the ICU, and 6th we will end with antimicrobial stewardship in the pediatric in pediatrics. And basically, we know that for the last 2 months, 2 years, the entire globe as well as our state has been fighting the scourge of COVID-19 pandemic. So it is actually a visible pandemic, and we know how much it has affected our lives. Whereas antimicrobial resistance is another pandemic, which is referred to as invisible pandemic, because we become aware of, even doctors become aware of this antimicrobial resistance only when ourselves or our loved ones end up in an ICU and get infection with a multi-drug resistant organism. Till then, unfortunately, we are oblivious to the threat of this antibiotic resistance. So it is in this regard that the WHO as well as all the stakeholders have come out with this global action plan, national action plan, as well as the state action plan. This is basically the theme of World Antimicrobial Awareness Week. The baseline theme is that every year the baseline theme is handle antimicrobials with care. Antimicrobials involves antibiotics, antivirals, antifungals, antiparasitics. So usually WHO uses the term antibiotic stewardship instead of antimicrobial stewardship to make it people friendly. So all these concepts are for the people to understand, because doctors are supposed to know all these things. So the antimicrobial is a term with which many of the people may not be able to relate to. That is why we use the term antibiotic stewardship. So this year, the specific focus is spreading awareness and stopping resistance. So there are multiple themes, one of which is always get advice from a healthcare worker when taking antimicrobial medicines such as antibiotics, antivirals, etc. So basically, this year the focus is on generating public awareness. And that has been actually our mission for quite some time now, how to engage with the public, how to engage with the civil society. And Ajin sir has actually charted out a beautiful a visionary plan, how we will be engaging with the school children, how we will be engaging with the women of the house, etc. That is the only way in which we can make the people aware of the looming danger of antimicrobial resistance. So today I will be talking about what is the need for having such a program in the state and how we are going to achieve this. To take you back to 1915, this was a promising poet. He's a UK British poet who died in 1915 following sepsis following an insect bite. He died because of a skin and soft tissue infection, which later on becomes sepsis, and he died because of lack of antibiotics, because the antibiotic era kickstarted with penicillin quite later on, maybe around say 20 years later. So he died because of lack of antibiotics or in the pre-antibiotic era. So whatever the modern medicine has achieved in the last 100 years, last century, is because of, to an extent, because of antibiotic, and as well as because of investment in bringing up sanitation, giving good clean water, air, etc. So it is only because of antibiotic cover that we were able to perform these transplant surgeries, transplant operations, complex surgeries, etc. And then 100 years later, we had this boy who presented in anaphylactic shock. This referred from under hospital where he had presented in anaphylactic shock following multiple wasp bites. He developed DIC, multi-organ dysfunction, had to be ventilated, had to be dialyzed. And on day 10, he developed central-line-related bloodstream infection due to pan-drug resistant Klebsiella, and he was referred to a hospital, and he died despite an antibiotic cocktail. If you go through the culture result in 2016, you can see that the Klebsiella isolate is resistant to all the available antibiotics in India at that point of time. So it is a pan-drug resistant Klebsiella. So within 100 years, we have exhausted. So what turned out to be, so the golden bullets, that is the antibiotics, at least some of the bugs have become resistant to this majority of the antibiotics that we are using. And this boy died because of a pan-drug resistant infection. Antibiotics could not save him. So in 100 years, what has happened to antibiotics? So this is basically the definition of multi-drug resistant organism, XDR organism, that is extremely resistant organism, and pan-drug resistant organism. MDR means non-susceptible to at least one agent in 3 antimicrobial categories. XDR, that is extensively drug resistant, means non-susceptibility to at least one agent in all but 2 or fewer antimicrobial categories. PDR means non-susceptible to all agents. In 2016, we did not have intravenous vancomycin or ceftazidime avibactam or minocycline, intravenous minocycline in India. So at that time, whatever antibiotics were available, including colicin, was resistant to Klebsiella. He died because of a pan-drug resistant infection. So the first patient, that is our boy Robert Brook, died because he was in the pre-antibiotic era, and this boy in 2016 died because at least that boy was in the post-antibiotic era. That is why we need to focus on strategies to salvage what is left of antibiotics. So recently we have been discussing about everything going on at Glasgow with relation to the climate change conference. Okay, so what is antimicrobial resistance got to do with climate change? The most important thing is antimicrobial resistance is often compared with climate change because both of them are so complex issues. Now there is no one short solution for taking care of these climate change related issues like that. You cannot, just by investing in the human sector, you cannot combat the scourge of antimicrobial resistance, because we need a really One Health approach. Around 70% of antibiotics are being used in animal husbandry. So in order to make some sort of a headway into understanding this problem of AMR, we need to realize that it is because of the intersection of the antibiotics are being used in the human sector, animal food is for treatment and control, disease prevention, growth promotion, etc. As well as we need to take care of this environmental, because the pharmaceutical effluents are flowing on to our rivers, etc. And antibiotic residues, antimicrobial resistant genes as well as resistant organisms are present in environment as well as sewage, etc. And will find its way into the food chain, and we will be consuming these antibiotic residues, resistant genes as well as resistant organisms. So basically, AMR is a major health, food security, environment, and economic threat. So in order to make a successful AMR combating AMR action plan, it has to be a One Health approach. And Kerala, we have multiple stakeholders. It's not only the healthcare sector, we have the animal husbandry, we have the dairy sector, we have the agriculture sector, we have the fisheries, aquaculture sector, we have the pollution control board, environment. Everyone has to work together to come out with a sustainable action plan. And that is what CARSAP is a sustainable action plan. And this is actually the threat of AMR. If you don't take action today, just like in climate change, we know that if you don't cut the coal emission by this much percentage, the temperature will go up by 2 degrees by the end of the century, etc. Like that. For AMR also, if you don't take some action today, by 2050, around 1 crore people across the globe are expected to die because of antimicrobial resistant infection. And that number is going to be more than the number of people who die because of cancer or road traffic accident, etc. put together. So the time to act is now. And now the flame of antimicrobial resistance is actually fueled not only by the misuse of antibiotics or the overuse of antibiotics, but the use of antibiotics itself can lead to drug resistance. It's a misconception that it is only the overuse or misuse of antibiotics which leads to resistance. This antimicrobial resistance is nothing but actually an evolutionary mechanism of the bacteria or the virus or the fungi. So it is actually a survival mechanism for them. If you are exposing them to antibiotics, they will develop some mutations to get rid of it. So use of antibiotics per se can lead to resistance. So that is why we need to use it in a very judicious fashion. So whenever we are using antibiotics, the concept is risk versus benefit. Now, the major causes of antibiotic resistance crisis are: one is the overuse of antibiotic, unregulated over-the-counter sale of antibiotics. We know this is a major problem in India. Even without a prescription, you can get antibiotics in India. So the easiest thing obviously will be like in developed nations to ban the over-the-counter sale of antibiotics. But that is not possible in a country like India, where a Lancet study was published saying that the leading cause of under 5 mortality in India is not lack of is antimicrobial resistance. It is lack of access to antibiotics. In states like Bihar, etc., you cannot find doctor in for kilometers and kilometers, and there if you want antibiotics, only way is to get it over the counter. That is why the government of India actually cannot ban over the counter sale of antibiotics. But in a state like Kerala, and the state cannot take a decision regarding banning the over the counter sale of antibiotics. The only thing we can do is to educate the public about the problems that we are likely to encounter if they take antibiotics without a doctor's prescription. In developed nations where OTC sale of antibiotics has been banned, where you don't get antibiotics from pharmacy shops, etc., there the problem is the online sale of antibiotics. You can get and you can purchase antibiotics online. That has to be regulated. Then inappropriate prescription, indication, choice of agent, and duration is incorrect in around 30–50% of cases. In the ICU, 30 to 60% of antibiotics are prescribed are unnecessary, inappropriate, or suboptimal. Extensive agriculture use of antibiotics. In agriculture, it is not only used for treating diseases, it is used for disease prevention as well as for growth promotion. This is very, very important. Around 60 to 70% of antibiotics used across the world is used in animal husbandry, not in humans. Only 30% are used in humans. So this will lead to the alterations in the environmental microbiome, and this actually can find its way into the food chain. That is the importance of involving this farms, etc., in AMR action plans, because the farm effluents can find its way into the water bodies, and from there it can find its way into our the food chain. It's very important. Then next important aspect is availability of few new antibiotics. The companies are a bit reluctant to invest in antibiotics because by the time an antibiotic reaches the market, maybe say 10 years or so, and then by that time the microbes could have developed resistance. That's very important. It's a net present value of a new antibiotic is only about $50 million compared to $1 billion for a drug used for myasthenia gravis. So the companies will think that it's better to invest in chronic conditions like diabetes or hypertension rather than investing in an infectious disease, because for example, if they invest in cholesterol, and we might require this cholesterol and fosfomycin only in our deathbed, so it is not lucrative for the company as such. Whether if they invest in diabetic drug, etc., we'll be taking for our lifelong, so for our entire life. So that is what is meant by net present value of an antibiotic. And now after 2016, in USA, etc., the government funding has increased because the private players are a bit reluctant to fund research in antibiotics. So the government had to step in, and they had this 2020 plan whereby they were planning to introduce 20 new antibiotics by 2020, and they introduced a lot of them, but it was for gram-positive infections and C. diff, which are not a major issue. That is, MRSA and C. diff are not major issues here, and we'll discuss about that. And the last aspect is the regulatory barriers. The drugs have to come through phase 1, phase 2, phase 3 trials, etc. But then we have a lot to learn from the COVID-19 pandemic, where we got a vaccine within, say, 8 months or so, like that, and the regulatory barriers, etc. They sort of, the regulatory barriers got adjusted, and probably for AMR also in future, these things might become a lot easier. And we need to understand certain myths regarding the genesis of AMR. So we always think that it is the inappropriate use of antibiotics which causes resistance. Actually, it is not true. It's the inappropriate use as well as the use of antibiotics itself can lead to resistance. So excessive inappropriate antibiotic use can lead to resistance, for which you will be using new antibiotics, which itself can lead to resistance. It is sort of an antibiotic paradigm or a vicious cycle sort of thing. So it is an evolutionary mechanism. So any antibiotic can lead to development of resistance mechanisms in the bacteria. In order to combat this problem, in 2015, the Global Action Plan for AMR was launched. In line with that, the National Action Plan got launched in 2017. And in 2018, Kerala became the first state to have a subnational action plan. It is referred to as Kerala Antimicrobial Resistance Strategic Action Plan, or KARSAP. So KARSAP has 6 strategic priorities or focus areas. The first is awareness and understanding. So where we focus on communication, education, training, etc. This part is actually very, very important. So this awareness and understanding is something which we look forward to spreading during the World Antimicrobial Awareness Week. So whatever is in white is supposed to be done by all the stakeholders. It is not to be done only by the healthcare workers. Whatever is in white should be followed by the health, by animal husbandry, aquaculture, dairy, fisheries, environment, pollution control board, etc. The second aspect is knowledge and evidence. We need to strengthen our laboratories and we need to have a very good surveillance network. Only then we will be able to identify the extent of the problem of antimicrobial resistance in the state. So to have very good antibiograms, etc., we need to have an extensive surveillance network. And I'm very glad to say that the most extensive surveillance network in India is actually the CARS-net, or Kerala Antimicrobial Resistance Strategic Network, where the nodal center is the NCDC site, that is the Trivandrum Medical College. And initially, 2016-17, etc., the members of this network used to be the government medical colleges and some NABH accredited hospitals. And later, in 2018-19, it was expanded to include, say, 22 other labs so that we can get a very good representative antibiograms. And we used to have very good data till, say, the start of this COVID-19 pandemic. Obviously, COVID-19 did impact the AMR action plans across the globe, and we were no exception. Third aspect is actually very, very important thing. The best way in which we can salvage our antibiotics is by preventing infection. So if we are able to prevent an infection from occurring, then probably we can also save on the need for use of antibiotics. So IPC in human health, IPC with regard to animal feed and food, environment, etc., are very, very important. The fourth is optimal use of antibiotics, and that is what we will be dealing with. That is antimicrobial stewardship. There are many aspects to this. One is with regard to regulations like this over-the-counter sale of antibiotics, then antimicrobial stewardship in hospitals and healthcare industry, then antimicrobial stewardship in veterinary as well as aquaculture, and then regarding the Ams Metrics. Now, if you don't measure the utilization of antibiotics in these industries, then we won't be able to make any change. The fifth is with regard to the research and innovations, and our partner, the research partner for CARSAP is Rajiv Gandhi Institute. And the sixth is actually the collaborations with NGOs and like-minded organizations. And this is actually a snapshot of what has been happening in Kerala. Means you can see that the percentage of ESBL producers, the state tracks as part of the state action plan tracks 4 gram-negative organisms. Acinetobacter, E. coli, Klebsiella, and Pseudomonas. And then we track 2 gram-positive organisms, that is Staph aureus and enterococci. So when we look at the percentage of ESBL producers in India, in our graph shows that probably the percentage of ESBL producers in Kerala is less compared to the percentage in India, but that is nothing to be happy about, because our aim is to bring down the ESBL production rate. And in India, it is around 65% in Acinetobacter. In the state, it is around 40-50%. And the carbapenem resistance is actually a very, very important, or you can say that it's an emerging problem. So when we talk about emerging infections, we always think about Nipah or COVID-19. So the antimicrobial resistant infections also should be considered in equal footing with that of an emerging infection. So carbapenem resistance is an emerging problem. So it has been here for quite some time, and you can see that carbapenem resistance is a major problem in Acinetobacter compared to E. coli or Pseudomonas or Klebsiella. And compared to the national average, probably this antimicrobial, the carbapenem resistance is a bit less, but that is nothing to be happy about. But then when we are interpreting the data from the national level, we have to understand that this data is coming from the ICMR network, which is the data from top tertiary care institutes like, say, the CMC Vellore, the BGH Chandigarh, STPGI, Ames, then the Apollo Group, etc. And these hospitals are tertiary care centers which cater to the sickest of the sickest. They will be in ICU for long periods of time. So this may not be the real resistance in the country, which is likely to be lesser. So that is the problem in following, say, a national policy or guidelines like that. Because if you look at the resistance from our Taluk hospital or, say, PHC, this much of resistance may not be there. So even between different medical colleges, the resistance rates are entirely different. That is the importance of having antibiogram for each institute. That is very, very important. You cannot have an antibiotic policy per se, because the resistance in one institute is different from the resistance in another institute. And likewise, even in the same institute, for example, Trivandrum Medical College has got around, say, 25 ICUs. The antibiogram between different ICUs are entirely different. So this is very, very important. The treating doctor need to have ICU specific antibiotics, only then they can treat the patients in a very, very effective fashion. When we look at the gram positives, we are looking for at MRSA as well as VRE. The percentage of MRSA in the state is around 40%, and VRE is not a major problem as of now. This is actually the trend in resistance. If you look at the data from 2017 to 2020, since majority of the labs had been converted to this the COVID PCR testing facility, the number of isolates were less. That is why the last, the bar is a bit higher. If you take away the 2020 data, you can see that the resistance, ESBL, etc., has been coming down a bit, but then it is almost static. For Acinetobacter at around 50 to 40%. For E. coli also, you can see. This is how using CARSNet we are following the resistance trends in the state, and it's based on these trends that we come out with the state-specific guidelines and all. This is actually a trend of carbapenem resistance in Acinetobacter, E. coli, Klebsiella, and Pseudomonas over the last 4 years. And so what we do with this data? So we have this surveillance in place, and based on that, we have a cumulative antibiogram for the hospital as well as the community. So this has to be different. So what is the antibiotic guidelines for our hospital may not work for another hospital. For example, if you are following the national antibiotic guidelines at the Taluk hospital level, it is going to drive the resistance rates only. Even the policy which is being followed in Medical College Trivandrum may not be required for a Taluk hospital or a PHC. That is the reason why. So everyone has to invest in diagnostics and has to have an idea about the resistance prevalence in your own hospital. And based on that, we come out with treatment guidelines and which is implemented through this Anti-Microbial Stewardship plan. This till then we have been covering about the problem of antimicrobial resistance, the emergence of drug-resistant microbes, etc. The next is with regard to the problem with antimicrobial development. So you can see that the resistant bacteria has been on the rise, whereas the lesser and lesser antibiotics are coming to the market every year. This is a major problem. So if you look at from 2016, actually because of the FDA 2020 program, many new antibiotics had come to the market. And you can see the meropenem, vaporbactam, imipenem, relibactam, omadacycline, eravacycline, plasmamycin, ceftibacter, ceftazidime, avibactam, etc. did come to the market, of which only ceftazidime, avibactam is available in India now. And there is a problem with ceftazidime, avibactam. So this drug is very effective against carbapenemase producing enterobacteria. But unfortunately, the carbapenemase in India happens to be this endium. And this avibactam, which is a non-beta-lactam, beta-lactamase inhibitor, is not capable of hydrolyzing endium. Around say 80% of the isolates, the gram-negative enterobacterial isolates in India, which are carbapenem resistant, which express carbapenemase, express endium carbapenemase. Okay, only around say 15-20% express OXA48. So that is a problem. Even though ceftazidime, avibactam is available in India, so it can't hydrolyze endium. There's a problem. So we go back to this slide. These are the newer antibiotics available, not in India, across the globe. The ceftazidime, tazobactam, ceftazidime, avibactam, meropenem, vaporbactam, imipenem, relibactam, aztreonam, eravacycline, plasmamycin, ceftibacter, etc. You can see that endium is the most prevalent carbapenemase in India. And of the new drugs, only the aztreonam, avibactam, eravacycline, and ceftibacter will be able to take care of endium producing enterobacteria. It's important, and these three drugs are not available in India. So what we do is that, so in patients who express this carbapenemase as meropenem resistant, if they can afford this carba-R assay is being done to see what is the resistance mechanism. If it is OXA48, because 20% of them might express OXA48 instead of endium, then probably you can get away with ceftazidime, avibactam. If it is endium, what we do is that definitely the ceftazidime, avibactam based therapy is superior to this colistin based therapy. And we don't have colistin breakpoints as of now. And then you can add aztreonam to ceftazidime, avibactam, because aztreonam can hydrolyze endium. The rest of the ESBLs can be hydrolyzed by this avibactam, so that aztreonam do not get hydrolyzed by other ESBLs. So the aztreonam, avibactam is not available in India, but instead we use ceftazidime, avibactam plus aztreonam. So what I'm trying to portray is that despite having this much of new antibiotics in market over the last 5 years, nothing is actually really going to help us. That is the problem. Now coming to the the healthcare associated infections. Usually the community-acquired infections do not have that much of resistance. These are healthcare associated infections which end up being due to this XDR or a PDR pathogen. You can actually divide this thing into healthcare infection can be divided into exogenous infections or endogenous infections. Exogenous infections are like say Acinetobacter or say Candida auris. The problem is with infection control. Okay, so if your ICU is having more of Acinetobacter, it means that your surface infection control is not proper. So you need to invest in infection prevention control if you want to bring the rate of exogenous infections in your ICU. Whereas if you want to target endogenous infection, like say Klebsiella, etc., or multi-drug resistant Klebsiella and all, you need to understand the concept of collateral damage. Collateral damage means that our gut is having good microbes as well as bad microbes. When you are using broad spectrum antibiotics, so the that broad spectrum antibiotic can kill off all the susceptible microbes in your gut, and the resistant microbes will become the dominant population. And if your gut integrity is lost, they can lead to infection. So that is the concept of collateral damage. Basically, collateral damage is the selecting out of drug-resistant microbes by the unscrupulous use of antibiotics. So the collateral damage as well as endogenous infections can be taken care of only by antimicrobial stewardship. So basically, this is the concept of collateral damage, and we need to understand the concept of collateral damage. It's actually very, very important because, for example, take the case of COVID-19. So COVID-19, we know that it does not require any antibiotic. It's a diagnosed case of COVID-19. But then the practice is that majority of the doctors still use azithromycin for treating COVID-19. So when we ask them why you are using azithromycin, they will say that azithromycin do not have that much of a side effect. So side effects are gastritis, so that can be taken care of by say pantoprazole. QT prolongation is very rare like that. So many doctors still think that when we talk about antimicrobial resistance or we should using antibiotics judiciously, we are talking about the perceptible reactions like say hypersensitivity or gastritis, etc. No, we are saying that antibiotics should be used only if it is really indicated because of the concept of collateral damage. Just see what the use of azithromycin can lead to. Azithromycin use can lead to the selection of macrolide resistance in pneumococcal isolates. Over the last 10 years or so, the macrolide resistance in pneumococcus has actually from around 3% has become around 35% in India. So that is what is happening. This is actually not directly evident to us, and that is why we continue using azithromycin. So it is not like using azithromycin for an influenza-like illness where we don't know the diagnosis. No, it could be say H1N1 or it could be mycoplasma, and someone thinks about using azithromycin. Yes, but it is not. The situation is different in case of COVID-19. It is a diagnosed case. Now there is no role for empiricism. Still, majority of the doctors are using azithromycin. That is the importance of having sessions like this. Where the idea is to convey about the concepts of collateral damage, etc. Because even the use of an antibiotic can lead to the selection of drug resistance in the colonizers or the gut microbiota, etc. And you are likely to get an infection due to the resistant organisms in future when your immunity is down. So what basically is this antimicrobial stewardship? So basically, antimicrobial stewardship is about using the right antibiotic at the right time, at the right dose for right duration for the right patient. The objectives of antimicrobial stewardship is actually to maximize the antimicrobial benefit, avoid harm from adverse reactions and drug allergies, improve the patient outcomes, decrease antimicrobial resistance, and decrease healthcare costs. So antimicrobial stewardship is actually not about not using antibiotics. It is about using antibiotics in the right way so that we can optimize the outcomes for the patient. So how do we choose an antimicrobial agent? So this session is actually sort of a curtain raiser for what is going to follow in the next 5 days. So how do we choose an antimicrobial agent? So we need to look at so many factors: the age of the patient, so the history, whether the patient is immunocompetent or immunocompromised, the comorbidities. And the next thing is what clinical syndrome we are dealing with. This is very, very important because majority of the students do think that fever is antibiotic deficiency or ceftriaxone deficiency, because the moment a patient comes with fever, the spinal cord level reflex is to write an antibiotic. Even in patients with diagnosed COVID-19, patients with diagnosed dengue fever, etc., residents means end up writing some sort of an antibiotic because everyone thinks that fever is antibiotic deficiency. And if you try to correct them, they will ask, what is the problem of giving, say, doxycycline for 5 days? What is the problem of giving azithromycin for 5 days? They don't know the concept of collateral damage. So basically, anyone is coming with fever, we need to ask certain questions. Is it likely to be due to an infection? If it is due to an infection, the next question is, what clinical syndrome we are dealing with? So it could be a tropical fever syndrome like leptospirosis or dengue or influenza or strep typhus like that. It could be a skin and soft tissue infection. It could be a bone and joint infection. It could be a pneumonia, which is a pulmonary syndrome. It could be a CNS syndrome, meningitis. It could be diarrhea, as a gastrointestinal syndrome, or a genitourinary syndrome. So the patient is coming with fever. See whether it could be due to an infection. If you think it is an infection, you try to identify the clinical syndrome. Once you have identified the clinical syndrome, then ask the next question. What is the likely culprit? So what is the predictable bacteriology, or could it be a virus like that? So that is very, very important. So identify the syndrome, have an idea about what organism is causing the problem. For example, the patient is having a dysuria. So you know that you're dealing with a genitourinary problem. You know the commonest organisms like, say, E. coli, Klebsiella, etc. Then next important aspect is knowing the local resistance patterns. For example, if the patient develops an urinary tract infection while in the ICU, etc., it is likely that the patient is going to have infection due to a drug-resistant microbe. This is also very important. The next aspect to be considered is when you are choosing an antibiotic. So you need to look at the efficacy of the antibiotic, safety of the antibiotic, resistance prevalence, and collateral damage. This is actually very important. So previously we used to, when we say a drug is the drug of choice for a particular infectious syndrome, we used to look only at two aspects. One is the efficacy and safety. It is over the last decade or so that other two concepts, the concept of collateral damage and resistance prevalence, have come in. For example, this is the drug of choice for uncomplicated cystitis, one situation where antibiotics are used maximally. So till around 2009, the drug of choice happened to be the fluoroquinolones. If you look at the fluoroquinolone efficacy, it is pretty good. The safety is also pretty good. But in 2010 and all, because of the problem of antimicrobial resistance, they revised the recommendation, and the fluoroquinolones were having an A1 recommendation that was sort of downgraded to B. It's not because of lack of efficacy, it was because of the problem of resistance prevalence and collateral damage. And nitrofurantoin and cotrimoxazole and fosfomycin became the drug of choice. You can see that these drugs are not as efficacious, or maybe having the same efficacy as that of fluoroquinolones, but the chance of resistance development and collateral damage for nitrofurantoin is very, very less. So now when we are selecting an antibiotic for a particular situation, we have to consider all these four events. So collateral damage we have explained. Then what do you mean by this resistance prevalence? So previously we used to say that your antimicrobial resistance is developing because you are not completing the course of an antibiotic. But the question is, who said that an antibiotic course is around 7 days? So suppose a week had around 10 days, will it be a 10-day course of antibiotics? So nothing is like that. Once the patient is better and the clinician feels that there is no need for a continuation antibiotic, you can stop it. So now the current concept is that the resistance is directly related to the inherent property of an antibiotics. Antibiotics are divided in two categories: antibiotics with low resistance potential and antibiotics with high resistance potential. Low resistance potential means the genetic threshold to development of resistance is high, like doxycycline. The antibiotics with high resistance potential means the genetic threshold to development of resistance is low. So our aim must be to select antibiotics with actually low resistance potential. And in order to aid us in that, WHO did come out with an aware classification in 2017, and they are using these traffic light symbols. You can see the green ones. Green one means, suppose you feel like prescribing an antibiotic, ideally it should be an antibiotic from the green or the access category. The watch category antibiotics means, or the amber, they use the term amber instead of yellow. So the amber means you need to be cautious, like the orange signal in the traffic signal. You need to be cautious while using antibiotics from the watch category. The red or the reserve category should be used only if there are definite indications. And we should be aware of this because WHO has set a target for all nations, all states, and all institutions to have 60% of the antibiotic prescription from the access category by 2023. And The next thing is that all the hospitals should be having its own antimicrobial use metrics, utilization metrics. 60% of antibiotics used in the hospital should be from the access category. Now let us see what are the access group antibiotics. The aminoglycosides belong to this access category. Amoxicillin, clavulanic acid, cotrimoxazole, chloramphenicol, ampicillin, then clindamycin, nitrofurantoin, doxycycline, metronidazole, etc. Then first and second generation cephalosporins belong to access category. If you look at the wash category, the quinolones, the third generation cephalosporins, macrolides, that is azithromycin, which is being prescribed right and left, happens to be an antibiotic from the wash category, whereas everything which is covered by azithromycin can be covered by doxycycline, which belongs to access category. So the thing is that if you want to prescribe macrolides, if you feel like prescribing macrolides, you have a very good option from the access category. That is the doxycycline. Vancomycin, anti-pseudomonal penicillin, carbapenems, and penem. Penem is a carbapenem, etc. belong to the wash category. And the reserve category includes acetonam, fosfomycin IV, fourth and fifth generation cephalosporins, tigecycline, the colistin, polymyxin, daptomycin, ceftazidime, avibactam also belongs to that. So there is one oral antibiotic in the reserve category that happens to be linezolid. If you look at the wash category, interestingly, the carbapenems are included under wash category. WHO has categorically said that based on your resistance pattern, the states or the country can decide whether carbapenem should be in the wash category or the reserve category. So this is sort of a broad guideline, and many of the countries have their own aware index and push this carbapenems from wash category to reserve category. So this is one study which actually look at the access watch reserve classification utilization pattern. It's a pediatric survey. You can see that the aim is to have 60% of prescription from the access category. The majority of the developed nations have been able to achieve that. Now, India falls somewhere in between. So as of now, even in pediatric practice, where we are not expecting that much of resistance. So around it is only around the access category use is only around say 30% in India. The only good thing about this graph is that the bottom line is brought up by China. So where the access prescription is only around say 20%. So the aim is to push up this access utilization to around 60%. So as part of this CARSAP, we have been doing this prescription audit, and this is one of the largest prescription audit which is done probably in India. There is around 12,000 prescriptions from the OPD were analyzed. So the most important takeaway message is that whenever we are planning some sort of an antimicrobial stewardship action plan, we'll be focusing on say medicine or say pediatrics like that. So what this study showed is that the use of antibiotics in ENT and say dental, we did not include in the study. Dermatology, etc. are also very high. So we need to focus on all these departments. Just going behind medicine or surgery is not going to give you dividends. So you need to have to identify the prescription pattern in your hospital. And you can see that from the OPD, this was done in 2018, 60% of the prescription is from the access category, 2% from the reserve, that is linezolid use, and 37% from the wash category. So what WHO said that we should achieve by 2023, it appears as if we achieved even in 2018. But here comes the catch. This is actually data from the OPD. So if OPD, the access utilization is only 60%, then what will be the access utilization if we take IPD and ICU, where especially in the ICU, though we will be forced to use antibiotics from the reserve category. So that is going to be a problem. So we want to achieve the WHO target of antibiotic utilization of 60% in the entire hospital to be from the access category. The antibiotic prescription in the OPD should be around say 98 to 90% from the access category, and it is actually possible. If you look at, so we'll be discussing it in the coming days. So these are the wash group antibiotics which are usually frequently prescribed in the OPD. You can see azithromycin brings up the major chunk of prescription. The wash category, cefprioxime, it's a third generation cephalosporin, which also comes in the wash category. Ciprofloxacin, cefixime, levofloxacin, etc. The most interesting aspect is that for whatever syndrome this is being prescribed in the OPD, so we do have, if you look at the national guideline or the state antibiotic guideline or whatever guidelines for OPD, the drug of choice are drugs from the access category. Drug, for example, for sinusitis or say pharyngitis, everything the drug of choice is amoxicillin or augmentin. These are antibiotics in the access category. So we should make all doctors aware that in the OPD, because OPD, the patients are relatively stable and we need to use only antibiotics to narrow the spectrum antibiotics and choose, if antibiotics are necessary, choose antibiotics from the access category. So this indication-wise distribution of ceftriaxone use, the hospital-wise ceftriaxone got prescribed for cellulitis, sinusitis, abscess, LRT, all these things, and these were not culture guided. The thing is that if you look at the treatment guidelines, ceftriaxone do not find mention for any of these indications. The antibiotics of choice happen to be antibiotics from the access category. So we have a lot to improve. Then indication for using linezolid. For example, MRSA, the patient cannot be hospitalized ICU. If it is a nosocomial MRSA, which is resistant to, say, clindamycin, cotrimoxazole, and doxycycline, the only choice, oral choice will be linezolid. But then it should be culture-guided use. If you look at this, the culture-guided use of linezolid was there only 20%. 80% it was empirical use of linezolid. And we are talking about empirical use of an antibiotic in the reserve category. So these are the things that we should be trying to change as far as we are concerned. So we should be able to change all these things. Then for respiratory tract infection, the antibiotic prescription pattern here also, even though the augmentin was was prescribed maximally, you can see that around 41% of the prescription was from the access category, and just because of use of azithromycin. So whatever azithromycin covers, doxycycline will also cover, and so probably azithromycin should be replaced by doxycycline. When we talk about antibiotic stewardship, there are two strategies. One is the front-end approach, and the second is the back-end approach. So based on our logistics and our expertise, each hospital should adopt either one of the following strategies. This front-end approach is actually very, very difficult. That is, formulary restriction or pre-authorization. It is actually not really practical. This means that the reserve antibiotic should be used only with the approval of the antibiotic stewardship committee of the hospital. So that may not be possible because at midnight, the patient may come in shock and probably the doctor will think about starting a broad spectrum antibiotic and then calling up the antibiotic stewardship committee at that point of time is not feasible. So it's not being practiced in majority of the hospitals. What is possible is the back-end approach, that is prospective audit and feedback. So based on the syndrome, based on the hemodynamic status of the patient, the doctor is free to start whatever antibiotic he wants to start. The only thing is that next day, the treating doctor or the antibiotic stewardship team, so which may not be there in majority of the hospital. So it is the treating doctor should reassess the need for antibiotics or optimize the use of antibiotics. So we can start whatever antibiotic we need to start, but then every day you need to have a relook at the need for continuing antibiotic and see whether such the broad spectrum antibiotics were necessary or not. So these are the interventions which can be planned. One is the automatic change from intravenous to oral antibiotics, dose adjustment based on, say, renal function or obesity, etc. Dose optimization, automatic alerts in situations where therapy might be unnecessarily be duplicated. For example, if you are combining, say, metronidazole with Paxil-Tazobactam, anaerobic coverage is there for Piptas, so there is no need for addition of metronidazole. Time-sensitive automatic stop orders, very, very important as far as surgical prophylaxis is concerned. Then detection and prevention of antimicrobial related drug-drug interactions, because the addition of more and more antibiotics need not be synergistic or additive. It could be antagonistic as well. So these are the things actually which can be practiced usually in the ICU, because ICUs are the epicenters of resistance. So when you are starting an antibiotic stewardship program in your hospital, so because of logistic concerns, we cannot do that in the entire hospital altogether. You select ICUs where the resistance rates are pretty high and focus on that. For example, in Trivandrum, so we initially, when we started off in 2016 or so, we selected ICUs where the prevalence of carbapenem resistance was more than 10%, and we started antimicrobial stewardship in such ICUs. So what we do is that starting smart and then focusing. So in the absence of bacterial infection, there is no need to start antibiotics. If the patient is, the clinically unstable, draw blood cultures and start antibiotics. So if you have started on broad spectrum antibiotics or whatever it be, the clinical review and decision should be revised at 48 to 72 hours based on the culture report. So if you are setting automated culture, and if you have a very good liaison with the microbiologist, it's very, very important. You can get to know the culture result within, say, 48 hours. And then at 48 hours, based on the culture results, you need to have an action plan. So if there is no evidence of the patient is clinically better, and if there is no evidence of infection, so if you had started an antibiotic, you can stop the antibiotic. The patient is clinically better, and if the culture reports are showing that sensitivity to a narrow spectrum antibiotic, you can de-escalate the antibiotic, or you can consider an IV to oral switch of an antibiotic. Patient is perfectly stable, even after 48 hours, you can stop the antibiotic. And if the patient is clinically stable, and if you want to send the patient home or to a nearby hospital, outpatient antibiotic therapy is another option. Most important thing is that whatever we are doing, we need to document all decisions, and this is something which we should be teaching our students and residents. And then the previous concept is that no, you need to complete the entire course of antibiotics. But then who said that the entire course of antibiotics, say, is 14 days or 7 days? Now we are having enough very good quality RCTs showing that the shorter is maybe actually better. For example, for community acute pneumonia, the clinical stability score is met. That is, the patient is suffocated for 48 hours. And if there is no evidence of, say, pneumonic effusion or abscess or any metastatic complications like meningitis or endocarditis, so around 5 days of antibiotic is as good as the previously thought 5 to 14 days. So, and then even for ventilator-associated pneumonia, now they are going with, say, around 8 days of antibiotics. Catheter-associated UTI around 5 or 7 days is as good as 14 days. Intra-abdominal infection. So this is following the STOP-IT trial. It said that even for complicated intra-abdominal infection, like, say, perforated appendix, if the source control has been done, 4 days of antibiotics is as good as 10 days. GNB bacteremia 7 days, so you can see osteomyelitis, then septic arthritis, so neutropenic fever, etc. In all these situations, a shorter course of antibiotic in RCTs. Now you don't get more evidence than RCT evidence. And some of these evidences are there. For example, you look at sinusitis. There are more than 25 RCTs saying that in a short course is as good as a long course of antibiotics. But there are certain exceptions. For example, a prosthetic joint infection, otitis media, streptococcal sore throat and pharyngitis, etc. Here, the conventional therapy may be better than a short course therapy to prevent relapse. So all these things are based on RCTs and probably the practice of repeating. So till discharge, patients may be getting some antibiotics. So those things need to change. This is what I was alluding to. That is the STOP-IT trial where 4 days of antibiotics was as good as 10 days of antibiotic if source control is optimal. So this is actually the POET trial, that is for endocarditis, partial oral versus IV antibiotic. This is from the Danish registry, which looked at around 400 cases of endocarditis. So the conclusion was, in patients with endocarditis on left side of the heart who were in stable condition, changing to oral antibiotics was non-inferior to continued IV antibiotic therapy. So for 10 days, they give IV antibiotics. And even for endocarditis, they are switching over to oral antibiotic if there is no complications. It's very important. The thing is that this is how the trials are coming out. So IV to oral switch can be done even for the diseases like endocarditis. After 10 days they are switching over to oral antibiotics, etc. This is a similar study for osteomyelitis, where oral antibiotics was found to be as good as IV antibiotics for osteomyelitis, for bone and joint infections. So now coming to the optimizing the use of antibiotics, what we were doing. So probably COVID-19 has set us back in a big way. But till then, what we were doing was that as part of CARSAP, Anti-Microbial Stewardship committees were set up in all the medical colleges, major hospitals, and NABH accredited hospitals, and at least the low-hanging fruit model for ASP was implemented. So antibiotic policy was updated every year based on the antimicrobial from the respective institution. Then Ams Metrics. So in Trivandrum Medical College, being an NCDC site, we used to calculate the Ams Metrics to assess the proportion of WHO aware antibiotics. The ASP modules and the digital antibiotic policies has been developed in connection with the KDISC, and it will be launched soon. It's actually an app-based ASP module which will help the students to learn more about this antimicrobial stewardship, also to optimize the treatment outcomes for the patient. And in select ICUs, we have been calculating the defined daily dose and days of therapy of WHO watch and reserve antibiotics. And state is actually set to achieve the goal of WHO target by 2023. For that, now every one of us need to work together. So a state has to follow the each one teach one model, because now there are a lot of doctors and there are a lot of other stakeholders. So whatever we are learning, we need to disseminate to others. Then we had the access to a clinical pharmacist in our hospital, and based on that, and we are an NCDC site also, we have been doing antibiotic utilization metrics also. So based on the surveillance, we are doing the AMR surveillance, healthcare associated infection surveillance, as well as Ams Metrics surveillance in select ICUs. So the Ams metrics. So whenever we say that we need to calculate, the percentage of the proportion of prescription from the access category, watch category, reserve category, etc. When we say that no, we don't have that much of infrastructure, we don't have logistics, we don't have trained pharmacologists, etc. So the most important thing is that in our hospital, we are doing it using the help of the trained link nurses, because they will capture the data from the select ICs. So this is something which we implemented in our hospital till around COVID-19, but COVID-19, everything. So when sort of, because there had to be a lot of rearrangements, and probably we'll get back to the pre-COVID era. So where we were practicing the low-hanging fruit model of antibiotic stewardship, which can be done in any hospital. That is, antibiotic prescription for inpatients have to be put under a bracket. This is what IMA said. Because nowadays the students do not know the difference between an antibiotic and paracetamol or cetirizine. So if we ask them to put them in a bracket, then probably they will realize that they were dealing with something which is different. Actually, while giving antibiotics, we are actually playing with fire if you are not using it properly. It is such a wonderful resource. It is such a precious resource. Okay. If WHO reserve antibiotics are prescribed, we need to document the reason for the same in the case sheet. For example, someone is prescribing linezolid in the OPD. We need to ask, what is the reason for prescribing linezolid? Suppose the patient says that, no, this patient has been colonized with MRSA in the past, well and good. We'll accept that decision. But a thought process has to be there. No, we should always encourage our students to ask why. If fever is there, they should ask why. Is it infectious or non-infectious? If they feel it is infectious, well and good. Then what infection syndrome they are dealing with? The predictable bacteriology. Only after that, they should choose an antibiotic. If we inculcate this habit, students should write all these things down while writing an antibiotic, and probably our future will be safe. If de-escalation is not practiced based on susceptibility report, the reason for the same has to be documented in the case sheet. Okay. The fourth one we have already discussed. If double anaerobic coverage is redundant, if double anaerobic coverage is given, the reason for the same has to be documented. Suppose the surgeon feels that an extra anaerobic coverage is if they are suspecting fecal peritonitis, and we actually don't know about the anaerobic susceptibility pattern of, say, carbapenems or Tract in situations like, say, fecal peritonitis, giving metronidazole for a few days may not hurt. But in usual scenario, we have to take it. We have to understand that piperacillin Tract, piperacillin sulbactam, carbapenems, vancomycin, linezolid, etc., do have anaerobic coverage, and there is no need to top it up with metronidazole for extra anaerobic coverage. If antibiotics are continued for more than 7 days, the reason for the same has to be documented in the case sheet. There are indications where you need to continue antibiotics for longer periods of time, like, say, osteomyelitis or endocarditis or empyema for leg abscess, like that. So the thing is that if you want to continue an antibiotic for more than 7 days, the resident should document it in the case sheet. So that thought process has to be there. If surgical prophylaxis is continued for more than 24 hours, the reason for the same has to be documented. So that is very, very important. So for clean surgeries, etc., even surgical prophylaxis is not needed. If surgical prophylaxis is given, usually it has to be stopped immediately after surgery. If that's not happening, the reason has to be documented. If more than 2 antibiotics are prescribed, the reason for the same has to be documented in the case sheet. This can be done in any hospital. So this is what we term it as a long-hanging fruit model for antimicrobial stewardship, whereby we are asking, or we are teaching the students to ask questions why antibiotics are being prescribed, and so if they follow the stepwise fashion, they will learn by themselves the basics of an effective antibiotic prescription. This is just to show the seriousness with which this AMR is being addressed by Scandinavian countries. This is a picture from Norway in 1995. they are vaccinating salmon. So in order to bring down the use of antibiotics in fisheries, salmon industry is a big industry for them. They, they are vaccinating the fish. That is the importance that the Scandinavian countries are giving to the problem of antimicrobial resistance. Now, what is the importance of why did we come out with the concept of this antibiotic literate Kerala campaign? So, as part of this CARSA, we did do a study to assess the knowledge about the optimal utilization of antibiotics in a cross section of public, and we found that even in those with the college degrees, etc., the awareness regarding the antibiotics, the effective use of antibiotics was actually very, very poor. So if you want to make a meaningful difference to antimicrobial resistance, we need to educate the public also, because if they go and take antibiotics from the pharmacy without prescription, etc., then there is no point. So actually, in 2019, during the World Antimicrobial Awareness Week, we did come out with the concept of making antibiotic Kerala antibiotic literate by 2021, but then obviously because of COVID-19 and all, so a majority of our activities had to be focused on COVID-19, and naturally it had to be like that. And now we have actually set the target of making Kerala antibiotic literate by 2023. So definitely it has to be a One Health approach. So we need to have champions from all the stakeholders. We need to identify champions to make Kerala an antibiotic literate state, or to have this campaign. One aspect is to focusing on the healthcare workers. So we are having this webinar series over 6 days to actually convey why the importance of AMR. Then from tomorrow onwards, how we can actually practice antibiotic stewardship in OPDs, IPDs, etc. So we have already said that only 30% of the antibiotics are being used by the healthcare. Okay, rest 70% is being used in animal husbandry. So we need to educate the students and teachers. So students are going to be our future, and educating the teacher means the teachers will educate students. So we have to have engagement with the students. That's very, very important. Ideally, the curriculum, the school curriculum should have a session on this, the antibiotic literacy like that. The civil society has to be engaged, and Kerala, the real game changers is women empowerment. So through Kudumbasri, we have to reach out to the women. Then we need to educate the farmers, the animal husbandry department, the fisheries, aquaculture, the pollution control board. All these people are together to educate the farmers. The pharmacist regarding, they should not be giving antibiotic without prescription will be educated by the drugs controller. Basically, we have to have a One Health platform. And the concept of antibiotic literate is to make everyone in Kerala aware of the ill effects of the inappropriate use of antibiotics. So these are the broad objectives under antibiotic literate Kerala campaign. Universal awareness about the importance of having access to antibiotic free food and water. This is very, very important, because we are a consumer state. So our poultry, suppose we can ban the use of antibiotic in poultry in Kerala. What is the use? Because we are not a producer state, we are a consumer state. Animal husbandry department has come out with something known as a Kerala chicken. That is a chicken which grown without, poultry without antibiotic being used. But around 90% of poultry are coming from other states where they may be using antibiotics for growing this poultry. It's very important. So since we are a consumer state, we need to educate the consumers, that is the public, that it is our right to have access to antibiotic-free food and water. Once the consumer makes such a demand, then the producers also will have to follow suit. For example, in USA, majority of the McDonald's, etc., they do advertise that they are using antibiotic-free chicken, but they are not following the same in the McDonald's in India. So these are double standards. So we need to make the consumer aware that they have the right to have access to antibiotic-free food and water. Then universal awareness about the importance of consuming antibiotics only on doctor's prescription. Then universal awareness about importance of safely disposing unused or date expired antibiotics. So what is being done is that, if you're having, say, azithromycin at home, just past expiry, or which you have not used, it will be dumped into a landfill or into rivers, etc. It will find its way into the food chain. So actually, the drugs control department has a unique program known as SPROUT, that is program on removal of unused drugs, which was piloted in Tirunelveli and certain districts where you can actually return the unused drug to the pharmacist, and there will be a central collection like that. The last objective will be the awareness among school students of the threat posed by AMR. So this is basically the roadmap. Just even though it was conceived in 2019, we could not take it forward. So it is planned in such a way that it will gains momentum from this year onwards, and probably our vision is to declare Kerala antibiotic literate by 2022, and even we will work in such a way that will become possible, and it's possible only with the help of all of you. We need to engage with everyone, the public. So we need to each one model has to be adopted. We need to engage with the students, with the industry, the civil society. We need to engage with the farmers, etc. And through a really a One Health platform, probably I hope that by 2023 and or by the end of 2022, we'll be able to make Kerala an antibiotic literate state. So these are the app-based ASP modules that we are using in CARSAP. The ID Consult was we have this private partnership also. ID Consult is an app developed with the help of developed by the ID practitioners in the state. It's a free app, and the MediBot, which has been developed by along with by the CARSAP team along with KDISC, will be launched in a month or so. The aim is to help all the doctors in optimizing antibiotic prescription. So thank you very much. So basically, alone we can do so little. Together we can do so much. Like what Helen Keller's story has taught us. So AMR is not my problem or your problem. It is everyone's problem, and we have to be in it together. We have to follow this each one teach one model, and probably we'll be able to achieve what has been envisaged by the roadmap of antibiotic literate Kerala by at least by 2023. Thank you very much.
Are you practicing formulary restriction after reviewing in 48 hours?
Actually, we are not practicing formulary restriction. It is actually basically pre-authorization. So there is nothing to do with 48 hours. We are practicing in prospective audit and feedback. That is, at 48 hours, we will review, and based on the culture results, we will decide on whether to de-escalate or whether to escalate or whether to stop, go for OPAT, etc. in select ICUs. And their question is antibiotic audit. Is there any guidelines on or checklist on how to perform an audit? Basically, the WHO, the guidelines are there on the poison prevalence survey, etc. And based on your logistics, your expertise, etc., you can either do calculate the defined daily dose of antibiotics or days of therapy. But actually, what we understood, we used to calculate the DDD of antibiotics in our ICUs, DOTs, etc. What is really meaningful is actually looking at the percentage of the use of access or watch or reserve antibiotics. It actually conveys a much better meaning than the antibiotic utilization metrics calculation from the pharmacy sales in government hospitals are not really reflective of the antibiotic use, because around 50% of the prescription might go outside. If you're having an e-health, means an electronic, in a private hospitals will be having an electronic dispensation, etc., then it becomes very easy to calculate the DDDs, etc. Anyway, you need to start somewhere. The easiest will be to look at the proportion of antibiotics used in the hospital which belong to access, watch, and reserve category.
The surgeon demands meropenem. What will be your stand? That is one question.
That's the importance of having an antibiotic stewardship committee. It's not about my stand, sir. It should be about the stand for all of us together. So we should make them aware that they should not be asking this question. It should not be that I will be saying there is no antagonism in it. So it is actually for me as well as for him. So we will educate him. That's all.
Any attempt to look at the microdata of Kerala and how it gets affected by antibiotics? That is the question by Use of Antibiotics.
Microdata.
Microbiota.
Microbiota. Actually, we did submit a study looking at the gut alterations in the gut microbiome in a hospital, and it was supposed to be done along with RGCB. And the plan was to look at multiple time frames. That is, at the time of admission to the ICU, 48 hours later, after 1 week, after say 2 weeks, to see the CRE colonization as well as what is happening to the CRE colonization. It was supposed to be a prospective study over 1 year. Unfortunately, the control group is selected from the relative, so that they will be having the same food pattern, etc., and did not get ethical approval. Okay, anyway, we are working on it, sir. But then there are beautiful publications on the same from animal husbandry as well as from we are having a SIFT they have around 70 publications on the fisheries, aquaculture, etc. And we do have the Pollution Control Board and the Fisheries University, KUFOS, etc., working on what is happening to our aquatic microbiome, etc. So work is being done, sir.